Hello and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Zachary Schwartz. In today's episode, we have a really engaging discussion on why, in the treatment of HIV, we shouldn't settle. We're joined by Dr. Monica Gandhi from Ward 86 in San Francisco and Dr. Luis Buzon from Burgos, Spain. To follow along with the slides, visit the show notes for this episode. But now let's get started. It's a really engaging conversation. I'm sure you'll enjoy it and learn a lot. Let's begin with Dr. Buzon.
Yeah, thank you for the invitation. I'm really thrilled to spend this time with all of you guys because this is a very interesting topic. Sometimes we think that the real interest of the front line of HIV is naive patients, is a thrilling setting, but switching patients from one treatment to another is a very, very important thing. And talking to colleagues in the last years, I've heard many times this kind of sentences: my patients are doing fine. They are suppressed. As long as they are suppressed, why should I move forward or switch a treatment regimen, which is definitely working? If they are suppressed, why should I change anything? That's quite a conservative opinion and a prudent one. But the question is, are we doing really fine staying as we are in every person who's suppressed? Or can we move forward? Can we improve what we're doing? I think that's the main question we're going to talk about, Monica.
Yes. I actually think that we now have so many options for HIV therapy that it is a time to discuss why we would want to switch. Maybe there are people don't even feel they're having adverse events. And as we know, efavirenz-based regimens were actually first-line therapy worldwide up till really 2018. They really dominated honestly, from the early 2000s for about 18 years. And so there could be low-grade adverse effects from the cognitive issues that could be associated with efavirenz. When you really dig deep, people may want to switch for a variety of reasons. And so I think that's what we want to talk about today. And I do think that when I talk to people, for other providers, because I'm a director here at the clinic, they'll say, well, what's the point of switching? As long as you have virologic suppression, that's the only goal of therapy. But I don't think it's the only goal of therapy is to achieve virologic suppression. I think it's a lot of other factors.
Yeah, absolutely. Quite a long time ago, suppressing viral replication was the main goal and the only goal indeed. And most of the times, patients had to deal with toxicities and even accept them because there were no other options. So as long as you were suppressed, that was a successful therapy. Of course, now the main goal is suppression replication. Of course, we can't forget that. But as of today, we gotta pay attention to many other areas which go beyond viral replication. And that's why we are talking about switching people and trying to improve their regimes when they are virologically suppressed. There's sentences like, my patients are doing fine. I wouldn't take it myself, referring to injectables, but there's no point in switching as long as they are undetectable. And I think we got to break this mindset as fast as we can, because people can do better just than being suppressed. And if you check the guidelines that you perfectly know, Monica, of course, the American and European guidelines, they are very clear about this. You should think about doing something else than, of course, getting viral replication suppressed. And guidelines are very clear, Monica.
Yes. The way I think of it is that, we used to be in an era, and we were both treating HIV then, where there were limited options and essentially whatever it took to get virologically suppressed. And I would counsel people through adverse effects, and we would just have to deal with it. And that was actually why we, for example, had the SMART trial, off and on therapy. We would take people off therapy because they had so many side effects that we wanted to give them a break. That is no longer the case with these increased options for HIV therapy. Integrase inhibitors have really been essentially kind of ruled through the roof since 2008, which was the first integrase inhibitor. 2018, 2019, the WHO recommended INSTIs as first line worldwide. Our countries and Europe and US had recommended INSTIs as first line before. We now have injectables, which I think is a huge thing to talk about, which we'll talk about, because issues like stigma, issues like privacy, maybe just not wanting to take that pill every day. We have a lot of people with housing insecurity who just cannot carry around even one pill once a day because that's how challenging life is. So there's lots of reasons to sit with someone and consider reevaluating their regimen if we need to switch.
Absolutely. Yeah. As of today, we had so many options, which have changed so much the landscape of treatment of people living with HIV. There is no point in settling down just in controlling viral replication. And I think we can start talking about whatever you want, any options and strategies and injectables, of course, switching to oral TUD strategies. And I think maybe the core of the question here in switching people who are virologically suppressed, they cannot go lower than one pill. When they are on STRs, of course, you cannot get better than an STR as of today. Then you have to think not only about the burden of pills, but about the burden of drugs. And my personal view is that, of course, we want to reach that point in which we can cure the HIV infection so that people stop taking pills. And we all be very happy with that, if that ever hopefully happens. But till we get there, it might be still a very long way to go. And it's very important how people walk this way. So the burden of treatment is a very relevant thing. So my question would be, are we over-treating a certain fraction of people? Do we really need 3 drugs for everyone or for almost everyone in 2025? We've learned from the past many, many lessons. First, you can get unexpected toxicities in long term. We have many examples, not only in HIV, but in a lot of medicine fields. Should we rethink if we are treating or over-treating quite a big fraction of people? Can we treat most patients with just 2 drugs with the amount of evidence we have? So the question is, why are we not switching people stable on 3Bs if a big fraction of them could quite probably be treated with 2 drugs? And I think this is a very relevant question every doctor should do to himself when treating people. Can I switch? Can I spare a 3rd drug? And I think that's a very relevant question, Monica.
Yeah, I mean, I think you're absolutely right on the 2-drug question. We've had sort of major trials and major considerations of 2-drug. And if you really think about how those 2-drug therapy trials have gone, and I'm thinking about dolutegravir rilpivirine, which is available as a 1 pill once a day, dolutegravir 3TC, which is 1 pill once a day, and now long-acting cabotegravir and rilpivirine. Really, the idea behind all of those were essentially getting rid of some of the NRTI backbone that can cause longer-term issues and toxicities. Frankly, tenofovir-based compounds or even abacavir, because, for example, TDF and even TAF can lead longer-term to renal and bone issues. And there has been a weight interaction, it seems, with the 2nd-generation integrase inhibitors like dolutegravir, bictegravir, with TAF. And we saw that for the first time in the advanced study in South Africa with that really shocking kind of increase in weight gain, more among women than men with the dolutegravir TAF FTC combination. So all that's to say the trials of dolutegravir, rilpivirine, dolutegravir 3TC, CAB, RIL are really around getting rid of that NRTI and just having 2 drugs.
Yeah, absolutely. I mean, the amount of evidence is overwhelming. If you sit down a couple of days and say, okay, I'm going to study all the evidence regarding industry-based TD strategies, you need more than 2 days because there are so many amounts of trials and good quality real-life evidence supporting their use that from my point of view, I mean, it really needs to be rethought by every doctor if I had to stay on 3 drugs. I don't want to put the focus on tenofovir only because it looks like we are trying to unprescribe tenofovir, and it's not that. I don't care if it's abacavir, tenofovir, or any other 3rd drug potentially existent. The thing is that you don't get toxicity, potential toxicity, after you're not taking something. So you don't get toxicity from something you are not taking. And as a patient with a chronic condition, if I was one, I would definitely be interested in knowing if I can treat as effectively and save my condition, whatever it is, in this case HIV, with less drugs, because this is a lifelong condition. I mean, we're not talking about treating 4 weeks of Hep C or 4 weeks or whatever. We're talking about taking days and weeks and months and years and decades of treatment. So it definitely makes a big difference sparing a 3rd drug. So you definitely have to think about switching to 2 drugs, regimens based on 2nd-generation ISTs. Dolutegravir rilpivirine, I think my perspective that it's never become that popular in the States, but it's been, for example, and it works really well. My personal experience is absolutely satisfactory. Dolutegravir lamivudine needs no presentation. And of course, you can use it in naive patients as well, which is beyond the scope of this talking. But the evidence with dolutegravir lamivudine is absolutely overwhelming. they have almost answered any question that were made with a very positive result. So why staying on 3 drugs? The evidence for switching is there, and we can talk specifically about the benefits, the potential benefits for people living with HIV with injectable treatment. I think the future is definitely parenteral and long-acting treatment, NRTI-free. There is a reason for that, and I think the future is going just that direction. So the sooner we embrace it, the sooner we step on this train of injectable treatment, I think the better we will do.
Yeah, I completely agree that I think it is the right time to talk about long-acting injectables. And I think we have been, at Ward 86, which is our clinic in San Francisco, we have been using a lot of IM cabotegravir recovery. We actually have now, we were just looking at our numbers, almost 500 people on long-acting cabotegravir recovery. And we used it without discrimination about being first virologically suppressed versus being viremic. That wasn't, again, how these agents were studied in FLAIR, Atlas, Atlas 2M, CARES, JABS, even all the clinical trials, SOLAR, they all looked at those who were virologically suppressed, switching over to long-acting Cabril. But we have such a low-income population, lots of challenges, housing insecurity, substance use. We wanted to try it in those with viremia, and we did. They've done great. They actually really like it for some of the reasons you were intimating: the privacy issues, the stigma issues, if you have a very hard life, just even one pill once a day can be hard. And so now the US guidelines, this just happened in 2024, ISUSA and what are called the Department of Health and Human Services guidelines, are two major HIV guidelines committee, changed last year, 2024, to say, yes, we have enough data in this observational setting from Ward 86 and others that if you're viremic and have adherence challenges and you really can't take oral pills, fine, use long-acting cabotegravir and rilpivirine in the context of viremia, which has opened up a lot more use in this country among really challenged populations. One other thing I wanted to kind of end with, which is the weight gain issue, because we did see from the ADVANCE study, which was published from South Africa, the idea that, we need to make dolutegravir worldwide. It got changed on the WHO guidelines in 2018-19. But before that, the study came out and this weight gain was seen with dolutegravir TAF. And I have seen it in my practice, with the TAF and the second generation INSTI combinations, maybe that potentiation of weight gain. And so I was always trying to switch to 2 drugs or change people off of that TAF INSTI with the hope that would lead to weight loss. And I don't think we have the evidence that switching ARVs is going to lead to weight loss. Just really recent data from that DO-IT study, so-called in the 5391 study from the ACTG, that if you switched that INSTI, and these weren't people, by the way, who were met the definition of obesity with a BMI of greater than 30, but if you switch them off of that INSTI and TAF to what we think is a regimen that doesn't have any weight effects, which is NNRTI regimens, specifically doravirine, even with TDF, which is supposed to help you maybe be weight suppressive. Anyway, there really wasn't a benefit in this small study of losing weight with that combination at 48 weeks, switching over NNRTI. So I'm dealing, and you are too, thinking about weight in the traditional ways we think about weight in the general population: exercise, nutrition, GLP-1 agonists are big in the United States, but I don't think we can make it go away with the switches of ART.
Yeah. I mean, my personal point of view regarding weight and antiretroviral treatment, this might be a bit controversial, but I don't think it's a major issue, at least in my ordinary practice. And I completely agree with what you said. Absolutely. But my question, Monica, for you is, okay,
the US, where weight is just, honestly, like, we do have an epidemic of weight gain in the US. In general, in the general population, and Europe has, I think, fought that harder.
Of course, maybe I did explain myself. Of course, it's a problem. It's a big problem also in Spain. But I don't think the main issue we have to think about when switching or trying to put one or another treatment. Okay.
Yeah.
Just for what you said. But I think there are some other things that are pretty more important at the moment to deal with regarding antiretroviral treatment. Of course, the way it is, but I don't think it's at the top of my relevant issues when deciding what treatment to offer to someone. And my question, Monica, is, okay, we have a lot of evidence, individual-based, community-based transmission in the community, stigma, perception, quality of life, telling you, okay, this treatment is definitely making a big difference for people, okay, injectable treatment. So my question is, it's 2025. It's been quite a long way now. It's not that it came yesterday to our lives. So why 4 years after, 3 years after we're using this, why is so many people so reluctant to using this treatment? Because I think it's very unfair to put the pressure on the patient's shoulder to be updated, to know scientific data, to know the potential benefits which they might know or not. Why do you think, Monica, we have some colleagues are still reluctant to use this treatment? Why?
I think that people change is hard for humans, and maybe even with providers. And then the other thing is, I think you have to keep really, and that's part of the reason we're doing this program, because now after this, every provider is going to sit and think, okay, should I be changing the regimens? And glad that we got to do this program together. But I will say that you have to be, the reason I like HIV medicine so much is you have to keep really on top of the data of antiretrovirals as all the data changes. You have to be really up with the data, which I find the most exciting part about being an HIV doctor, that you are always learning and things change so fast. And I just love that we've been in a field, where we have now these opportunities to discuss with our patients all these different choices and what would make them feel better, and having those really directive conversations and saying, no, I really think you could be better off if we try to simplify this or use this.
But on the other side, I think one of the elements explaining reluctancy is fear to failure. Okay, fear to failure, and this is a very tricky thing to talk about, because it's not a minor thing. Having a virological failure, of course, not a minor thing. We never go through it, explain to the patient, okay, this failed, the treatment failed, you didn't fail, the treatment failed, so got to switch back. But on the other side, if you check all the real life evidence and trials, we can say quite loud that the vast majority of people undergoing the virological failure get back to an STR, most of them, and are successfully suppressed again. So at the end, you can put it the other side. Okay, this might fail. The treatment might fail, not you. You can never get the blame on you again of not taking the treatment. It's the treatment that failed. It's not you. And if that happens, which is quite unlikely, you can most easily get back and get suppressed with an STR. That's what the experience is telling us. So I think that should help us reframe the virological failure with carboplatin and repeat. And of course, we don't want it to happen. That happens, it's the way it is. And we don't understand it that well yet, I think. With the courts, we can explain it either. There is people failing without baseline factors, the classic factors. No, that's going to happen. But if that happens, we can get back to an STR most easily. So don't you think we should somehow, Monica, reframe or rethink the meaning or the dimension of a biomedical failure in 2025?
Yes, I think we should. And I think that we should also, there's this idea that if we don't ask, we won't know. Both in the SOLAR study, which is that study that looked at people switching from big TAF FTC to long-acting capitated rilpivirine, when they asked, people said, actually, I feel a lot of internal stigma or external stigma from taking a pill. It reminds me I have HIV. That is not something that you will elicit unless you ask someone, like, what does it feel like to take that pill? Does it elicit any feelings in you? And then when they asked people in SOLAR, the advantage of going over was because they felt worried about sort of admitting to themselves they had HIV. So sometimes we don't even realize that people get reminded of their HIV status by swallowing a daily pill. And there's reasons to have those conversations with people where I actually don't think we always do, where we just take a while, sit down with the patient and say, let's talk about this experience that you have when you take your pill every day. And you'll find out unexpected things. And then that's when you say, okay, I have this option for you. I have this option for you. We could do this every 2 months. You don't even have to think about it in between. I have two things I say to patients when I first see them with a new diagnosis. I say, you should not even have a single side effect on this regimen. If you do, that's my fault. And we're going to keep on checking in about that. You always have things to switch to. And then later, I say to them, let's keep on reevaluating. We all have other options. Let's talk about your experience of taking this pill every day. So regular communication, shared decision-making, and there's so many, I don't know, I feel really lucky that we're in 2025 and we have all these options for people.
You said a very important thing. You don't ask, you don't know. You got to ask. And
Right.
you're going to discover a lot of stuff. For example, we have a Spanish cohort I'm working at, which is called Relativity. And we're going to present in 90 week now around 400 people over 60 years old. Okay, on cabotalular repapering. Why I say this? It's not a promotional thing. What I mean is that it was very striking to discover that within people over 60 years old, more than half demanded treatment. They were the ones saying, please remove this pill from my treatment. And most of them were on 5, 6, 7, 8 pills. So you might think, I mean, they're over 60, they are taking 7, 8, 9 pills for whatever the chronic conditions. They shouldn't make a difference because nobody's going to ask, you are taking 9 pills. Can you tell me each one of them? What is it for? It's not like someone who's 25 years old who's probably not taking anything but the HIV pill, okay? It's not like that. A lot of people in our cohort in Spain, it's a very big cohort, 400 people over 60 years old, and a big fraction were demanding to remove the HIV pill. So stigma is not something affecting people who's 25, who's an MSM, who's this race or the other. It's transversal, and it happens to people over 60 as well. So you better ask, because there is no way to predict who's really suffering and how can you help them to get by. That's my opinion.
I really love that because I once interviewed someone who's in long-term remission. The very few people, some people only who've achieved cure, but this particular person said, I was on a lot of other pills, but it was the HIV pill that I wanted to remove. It was that one. Stigma is like, you cannot underestimate this. So I just loved having this conversation with you today. I think we talked about 2-drug therapy. We talked about the evidence for that. We talked about side effects or not with weight loss, but we also talked a lot about long acting, which I think is the wave of the future, new treatment paradigm in HIV. And I think we ended with what exactly you just said. You will never know if you do not ask. And I've had many examples where I had those conversations. We switched it to people and they are actually so much. I have a person who every time she took an HIV medication, she used to throw it up. And I would say, what was this nausea about? And she admitted to me that it again made her remember that she had HIV, and it was her body rejecting the idea that she had HIV. Got her on long acting. We just talk about everything else now because she's doing great. So anyway, it was a pleasure having this conversation with you. Thank you so much.
Yeah, likewise, Monica. Thank you very much for sharing this time with me, and thank you for the invitation. I really appreciate it. Thank you.
Well, thanks to you, Dr. Gandhi and Dr. Buzon, and thanks to you, our listeners, for joining us. I'm sure you enjoyed this conversation. To view more on this program, click the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease podcast on your favorite player. Thank you, and we'll see you on the next podcast soon.